if you just want to go ahead and introduce yourself, talk about your role, and where you're from. We can see it in the background, but
Okay. My name's Athos Bousvaros. I'm Vice Chair of Clinical Affairs in the Department of Pediatrics at Boston Children's Hospital. I've been a practicing pediatric gastroenterologist for over 35 years, and my interests are inflammatory bowel disease and also cyclical vomiting syndrome.
perfect. Thank you. How long have you been treating CVS patients? Has that been the entire 35 years?
Yes.
Perfect. Did you have something that got you interested in CVS, a particular patient or um,
I I always was interested in these patients, but over time, as I learned more about it, what I realized is that there weren't a lot of doctors that were comfortable diagnosing it or treating it, and you could take sick kids and make them better pretty quickly. So that was my main reason for being interested in it, something you can treat well.
perfect. Thank you. So what would you say CVS is?
Well, I think the term CVS is a constellation of symptoms for which there are different causes. But the vast majority of our CVS that we see, I would say over 90%, is an atypical form of migraine. In other words, it's mediated through the brain, not through the stomach, okay? Where basically kids can be well 1 minute, and then you get an on-off switch that flips and they vomit their brains out for a few minutes or a few hours or sometimes a few days, and then that switch flips off again, and then they feel better again. So, an atypical migraine.
And that's perfect for explaining to families because that's probably one of the hardest things to explain to somebody. So I like that. It's perfect. Uh, what are some of the subtypes of CVS that you see?
So the first thing I think about when someone comes in with a CVS pattern is I want to make sure they don't have anything else going on. So, brain tumors is one thing we want to rule out. Malrotation is another condition where the intestines are twisted on itself that we want to rule out that. Kidney abnormalities and then metabolic disease. So those are the things we want to rule out. I'll stop there. And
No,
then
that
I
was
can get,
perfect. That was another question I
okay.
had, kind of the
Okay,
test.
then
What test do
yeah,
you do?
because I didn't want to launch into subtypes without talking about the other things, okay?
Right.
In terms of subtypes, to be honest with you, there are a lot of different subtypes that have been reported. From my perspective, I treat them all fairly similarly. So, B. Lee, who's one of our experts, has basically gone into a subtype called Sato syndrome, which is young kids often presenting with severe hypertension. There's another syndrome where basically it's called the long cycle CVS, where basically they're very difficult to treat and you get episodes like clockwork every 3 months. But the vast majority of the CVS I see, they basically are migraines. That means they can be treated, that means that sometimes you don't know what triggers them, other times you can identify triggers.
Perfect. Let's see. Do you have one thing that you think is common that you tell all of your patients' parents?
So the first thing I tell them is, I'm glad you made it this far because it often is hard to diagnose it. The second thing I say is that there is no one diagnostic test to prove it's CVS. We don't have blood tests or x-rays or things like that tell us. And in fact, when patients come to the clinic, they're usually fine. They're usually not sick. So the diagnosis of CVS is really based on the history. And there are three components to the history that I look for. The first is you've got sudden episodes of vomiting that come and go without explanation. So paroxysmal episodes. The second is they've had multiple episodes and they're all fairly similar, not identical, but fairly similar. These are called stereotypical episodes. And the third is in between episodes, they return to baseline. So if you're a healthy athlete, once it's over, you become a healthy athlete again. If you're a child in a wheelchair with reflux, once the episode is over, you kind of again return to baseline. So those are the three things I look for: sudden onset, sudden disappearance, recurrent episodes that look the same, and then return to baseline.
Perfect. You bring up tests and ruling out some of the other conditions. What are some of the tests that you use to rule out other conditions?
Yeah, so when I see a patient in the clinic, I like to get, even if they're well, I like to get baseline blood tests, including blood count, liver tests, pancreas tests, and also celiac disease. Those can tell you a lot, just to make sure you're not missing any of those. Then I will typically do an upper GI series, which is have a patient drink some barium, take pictures of the stomach. That's to make sure the stomach is in the proper position and there's no twists in the intestine. I will often do an ultrasound to rule out gallstones, kidney stones, or a rare condition called UPJ obstruction, where urine has trouble flowing out of the kidney. And then sometimes, but often, I tend to have a low threshold for doing this, especially in a young child. I will sometimes do an MRI just to make sure there's no cyst or tumor in the brain. Many of my colleagues say that's probably overkill, and that's okay. But I'm not quite as comfortable with my neurologic exam, especially in a toddler. It's maybe some of my colleagues are. So I will sometimes do a brain MRI. And then for patients who, are having recurrent episodes or frequent triggers, I will have them come during an episode to the emergency department, and we do a large number of blood tests during the episode to rule out what are called metabolic diseases. If you want me to talk more about that, I can.
I have actually seen your guys's request for the emergency room, and I think that's lovely that you guys can get the emergency room to run those tests for you to help in your diagnostic and treating. So yeah, I would love to hear more about that.
Okay, so there are, again, to emphasize rare diseases, and I want to emphasize most cyclical vomiting is migraine, but there are certain rare diseases of what's called metabolism, which is your body's ability to break down toxins that build up in your body, okay, that need to be diagnosed at the time of an episode. For example, a rare condition called ornithine transcarbamylase deficiency, which is a defect in ammonia metabolism, usually now picked up at birth because we have screening. But you want to check an ammonia when they're vomiting during an episode. Another condition we think about is short chain fatty acid or medium chain fatty acid oxidation defects. And again, there are certain blood tests that you need to run at the time of the episode when a child is vomiting, and ideally before they've gotten IV fluids to pick those things up. Now, often these kids are sicker. They have other things going on. They have altered mental status. They've failed to thrive. They may have other things. But it's one of those I's we like to dot and T's we like to cross to make sure they don't have anything else going on. So what I tell a family is, here's your piece of paper, or I'll put it in the chart. When you come in, tell them, I'm Dr. Bousvaros's patient. Here's the tests you wanted done. He wants done, and it's usually blood count, chemistries, liver tests, urinary tests such as acylcarnitines, things like that, and then plasma amino acids, urine organic acids, and ammonia. So a few specialized tests. In general, they only need to be done once.
Perfect. I appreciate the thoroughness. I would say, especially as a parent.
Mhm.
Um, what do you think the most underutilized tool for managing CVS is?
I would say preventative medication. So, because, and I'll get into this, some of the medications that we use to prevent either have side effects or they're better known as, say, antidepressants or something like that. I think preventative medication is underutilized. So sometimes I see, parents whose kids have vomiting episodes every, couple months. And maybe they're not that bad, but they're missing a couple days of school with it, or they're kind of sick. They never know when the next one's going to happen. And usually I offer them preventative medication, but some parents are a little scared, so it's a little bit of a long discussion. Now, if someone has an attack once a year, you don't need to use preventative medication to treat a once a year attack. You can just, go to the emergency room, get IV fluids, get Zofran or whatnot. But for kids who are having frequent episodes, or those episodes are really affecting their quality of life, I think preventative medication is underutilized.
Perfect. That's I like that you address the sliding scale of treatment, right? That it really is based on the severity of the episode. That's I think something that a lot of people have questions on, right? They're only having problems a couple times a year. Do they need
Yeah,
to be on medication? So
yeah.
I appreciate that you
Yeah, I
brought that up.
mean, and certainly not everyone needs preventative medication. I mean, the goal is to reduce the frequency and the severity of episodes, right?
Hmm.
So again, if you're having one once a year, that lasts a day, it's okay, right? You just treat it. If on the other hand, you're having them once a month and they're lasting a couple days, or kids are really nervous or anxious, when's the next one coming? What's it going to affect? I think there's good opportunities there for preventative medications.
I agree. I think that was part of a good plan that we had for treating ours was talking about how you are always anticipating when the next one is going to come, and that just kind of creates more of the cycle, to the cyclic vomiting that, worrying about it. So having a plan of action definitely can reassure some of those patients. So I like that approach. What about pre-treatment? Do you, for having your patients and parents, when you talk about pre-treatment prodrome,
Mhm.
and making sure they're, kind of giving everything to
Yeah.
that, right? They're abortives rather than kind of being reserved. Do you have something you tell patients and parents there?
So it's a relatively common question I get from a parent. And the most common medication we use to treat an acute episode is ondansetron or Zofran. Sometimes we will use anti-migraine therapies or other things. But it's a common question I get from parents. When should I do this? Should I do it when I think it's starting? Or should I do it after it's going on? And I usually tell a family, this is a pretty darn safe medication, and I'm talking about Zofran now. And if you think it's starting, okay, there's no downside to giving it early, okay? You don't have to wait until the child is, in a full-fledged episode, because that will be harder to break. And in my experience, and that's all it is, if you give the medicine early, whether it's Zofran or Zofran and, a non-steroidal or an anti-migraine, you're better off. The other thing is that the medications that we use to treat migraine or nausea for them are all pretty safe. I mean, and so it's not a big deal if they get an extra dose or two. So I will also say that often the child knows when it's starting. They can tell you. And I tend to trust parents' sense. So you don't have to overthink it. Just if you think it's going to happen, give it.
That's a great advice because it really does, right? Parents are going, do I do it? Don't? It's like, is it too soon? And we learned to um, contemplate the triggers, right? If we knew it was going to be something that would set them off, if it was something we could pre-treat, get ahead of, because, I'm sure you see the same thing. Once it starts, it doesn't stop till it's done.
Well,
So,
the other thing too is that there are kids who just have very severe attacks, and they're going to end up in the emergency department, right? They're going to need IV fluids or whatever. And IV fluids, as you know, are remarkably effective at making children feel more comfortable, right?
mhm.
So again, I tell parents, if you know they're going to need the emergency department, take them.
That's a question we get a lot. It
Yeah.
always kind of terrifies me when I see people posting on social. Should I take them? Should I not? If you're asking the question, you
Yeah.
probably need to take them.
Yeah, and you don't want a child, vomiting for 8 to 12 hours at home and getting dehydrated, and often with the really bad attacks, you just can't take any fluids.
Yeah. Yeah. I have, as a parent, a lot of experience
Mhm.
with that. So yeah, 100%. What are some of the triggers that you see that you notice that you tell people to watch out for?
So I would say the majority of my patients who get into episodes don't have triggers setting them off. But when I think about triggers, I think about either negative stress or positive stress. I will talk about positive stress first because this is often underappreciated. But when kids go on Christmas holiday to grandma's, that's often when it hits. When kids are going on a school trip, with the other kids, or they're going overseas to Europe, that's often when it hits. So, I do find that, vacations or trips or disruptions in routine, which one would consider positive things, can sometimes set off episodes. Not always, not consistently, but something you got to think about. Doesn't mean you shouldn't go on trips. The negative stressors, I would say probably the most common one I see is related to school, related to tests, things like that. A school play sometimes, a track meet, things like that. And then the other kind of more obvious stressors are infections. So typically, upper respiratory infections, fevers, and things like that. And I think this is often why it gets misdiagnosed by pediatricians because a patient with CVS, there could be three other people in the family that have the same virus, giving them a little bit of nausea, vomiting, and diarrhea, but it might hit that child with CVS or adult with CVS a bit differently. And that's the child that's going to, again, vomit for a few days. So again, if a patient comes in once and a pediatrician says, yep, probably a virus, that's fine. But if they come in 5 times with the same thing, well, maybe you should think about something else.
Perfect. Yes, that's yeah, I like that. I need to look at it sooner. So, let's see. I don't think I had anything past. I think those were kind of the one things that we were looking at for questions. A lot of these are, frequently asked questions that,
Mhm.
I'm sure you experience in your practice as well. Do you think there was anything that we may not have covered for some of the questions you hear?
I mean, here's what I would say. And I'll be frank, I haven't really looked at the CVSA website materials recently, but I've been giving a similar handout. In fact, it's a handout I drafted for Kathleen Adams many years ago because there wasn't one handout that would just educate people about CVS in 3 pages. I don't know what you guys have now. I remember she wanted to use it, but then it went to committee, and I don't know if it's out there now on your website or not. But I think people should take the time to just learn the basics about CVS. And I think that can be, if you have one document on your website that you can point to that's 3 pages that has the information, I think that's great. I think gikids.org, which is the NASPGHAN website, has a nice little bit on cyclic vomiting to the best of my recollection. And then I guess I would emphasize is, uh, you know, uh, once you have ruled out those other things, treat your child. Now, the treatment plan can vary from patient to patient, depending on the physician's expertise, how this is affecting the quality of life of the child, how risk averse the parents are. And there are some parents that say, oh my gosh, I don't want amitriptyline. You've scared me. So you can start with dietary supplements. In my perspective, they're not, super effective, but you can always start there. But don't be afraid to, to treat the child if they need treatment. And then the other piece is this is a chronic illness, and like many other chronic illnesses, it can affect child's mental health. Stress and anxiety are not the cause of this, but this illness can cause stress, anxiety, and depression. So for some patients, having a psychological support also can be very helpful.
Perfect. I am a big believer in that as well. I think it's hard to explain that to a lot of parents that yes, it is considered a chronic illness. A lot of parents have a hard time with that term. I know I did.
Well, the other
So
thing I'll say is most kids do outgrow it. You know, I see a lot of kids between, say, the age of 3 and 10, and then I rarely see them as adults. I don't know if you want to get into cannabinoid hyperemesis for this particular project. I mean, I don't know how many older teens you want to reach, but I do tell my patients with CVS who smoke weed, I can't guarantee you that this will stop if you stop smoking weed, but I can guarantee you it will persist if you keep smoking weed. I tell that. So, that's something else that I think we're always thinking about in the differential diagnosis, besides the things I'd mentioned, not in the younger children, but obviously in the high schoolers and stuff like that. I mean, cannabis, I don't, which state are you in, Linda?
California,
Yeah, so cannabis is there, cannabis is
it's
here.
everywhere.
Yeah, okay.
Even in the States, it's not legal in.
Right, exactly.
And there is a really, the uptick in the adolescents using. Um, and some of the parents that come on the support calls or seeking support, they've been looking for answers for so long that they have gone down that road,
Yeah.
which terrifies me. You
I
know,
mean, yeah, I think cannabis is probably not a good thing to use for CVS. I think that they're, and again, you'll probably have someone else talk about medical therapy in more detail, but for me, it's cyproheptadine, and for preventative, cyproheptadine, amitriptyline, and then once it's past that, I'm often partnering with a neurologist because they have more comfort with managing the more seizure med like drugs that we
yeah,
use to treat migraine, the Keppra, the Valproate, things like that that I don't use as much,
yeah,
Tegretol,
parallel.
Topamax, all of them. Okay.
Yeah, yeah. That's what my son ended up with was neurology.
And which
So
what drug is he better?
he's 26 now.
That's good.
And it's very funny because from where he was to where
Mhm.
he is now, because he was long episode, his were 2 weeks long. He would vomit
Mm.
for 2 weeks, be fine for 2 weeks. Now he's down to 3 to 5 days a month that he just really has to work on
Good.
controlling the
And
nausea.
what's he on?
Right now he's actually, he does just supplements
Mm.
with B2 magnesium are his
Okay.
preventatives after they had to get him under control. They got very aggressive with getting him under
Mhm.
control. And then we worked backwards
Does he
to
have an
getting,
adult GI? There aren't many that do this.
no.
Yeah, it's
We
hard.
we we ended up transferring to adult neurology.
Hmm.
And our very first appointment with her, she told him he couldn't have CVS because he was an adult. And it was a week after he'd gotten out of the hospital for his treatment.
Yep.
But no, they ended up having to do the Raskin's protocol for DHE, the dihydroergotamine.
Okay.
Um, and they had to get very aggressive with him. And yeah, we went through everything: propranolol,
Mm.
Topamax, nortriptyline,
Well,
ketamine.
fortunately, 95% of patients are not as challenging as your son, thank God.
Yes,
And it sounds like you're the right person to lead this organization. So happy to help. And if you need anything else, let me know, okay?
I appreciate it. Thank you so much for your time today and willingness to work with us.
Have a great day now.